Welcome to the lecture on health systems around the world. In this lecture, we will discuss the following. First, we will define and discuss a health system. We will then talk about the concept of healthcare as a basic human right. Next, we will move to discussing the four main models of healthcare that exist around the world. Finally, we will talk about the U.S. healthcare system and compare U.S. healthcare to other healthcare systems and outcomes globally. So first, what is a health system? The official World Health Organization definition says that a health system is all actors, institutions, and resources that undertake health actions, where a health action is one where the primary intent is to improve health. So in other words, health systems are any and all of the following. They are agencies that plan, fund, and regulate healthcare. They include the money that finances healthcare. They are preventive service providers, clinical service providers, and specialized input providers. Specialized input refers to those who provide health education, production of drugs, and medical devices, among others. A health system has three main overall goals. They are to ensure good health in a population, to be responsive to the needs and expectations of a population, and to ensure the fairness of financial contribution. This is the World Health Organization's health systems framework. The World Health Organization states that there are 6 system building blocks that work together to produce goals and outcomes. The system building blocks are leadership and governance, healthcare financing, health workforce, medical products and technology, information and research, and service delivery. These 6 building blocks all work in conjunction with one another to produce the 3 main goals of a health system that we discussed on the previous slide, as well as improve overall efficiency. The way in which health systems are organized is heavily dependent on what type of country they are in. Most low-income countries have very fragmented healthcare systems that include a mix of public and private providers. Many middle-income countries such as Brazil, South Africa, and Thailand, have a system that is organized around a national insurance scheme. Almost all high-income countries have a national health insurance system. The exception to this is the United States. The Declaration of Alma-Ata was adopted at the International Conference on Primary Healthcare in 1978. At this conference, health was declared as a human right. In fact, the World Health Organization was quoted as saying that the right to health is relevant to all states. Human rights often overlap with other health-related rights, as represented in this World Health Organization diagram. Based on these principles, most nations strive for universal health coverage. Each nation's health system is a reflection of several issues. These include the nation's history, its politics, its economy, and its national values. All healthcare models vary to some degree. However, they often share several common principles. There are 4 basic healthcare models that exist around the world, and we will discuss all 4 of them in the following slides. The first model is one called the Bismarck model. It was named for the Prussian Chancellor Otto von Bismarck, who invented the welfare state in Germany in the 19th century. Despite its European heritage, this system of providing healthcare would look fairly familiar to Americans. It uses an insurance system. The insurers are called sickness funds, usually financed jointly by employers and employees through payroll deduction. Bismarck-type health insurance plans have to cover everybody, and unlike the U.S. insurance industry, they don't make a profit. Doctors and hospitals tend to be private in Bismarck countries. Japan actually has more private hospitals than the U.S. Although there is a multi-payer model, for instance, Germany has about 240 different funds, tight regulation gives government the powers of cost control. The Bismarck model is found in, of course, Germany, but also Japan, France, Belgium, Switzerland, and to a degree in Latin America. So let's take a closer look at Japan. Japan uses publicly financed health insurance. Citizens are mandated to enroll in one of the plans based on a number of factors. Most people in Japan are covered by this public insurance. Private insurance plays a small role in coverage. All public plans cover the same benefits package, which covers hospital, primary, and specialist ambulatory and mental health care, approved prescription drugs, home care services by medical institutions, hospice care, physiotherapy, and dental care. All enrollees pay a 30% coinsurance for services received, except for children, who pay 20%, and low-income citizens, who pay either 20% or 10%. Certain expenditures are tax deductible. Citizens also have a safety net, which stipulates a maximum monthly out-of-pocket threshold, which varies according to age and income. For example, US $761 for people under the age of 70 with an average income. There is an annual household and long-term care out-of-pocket payment ceiling, which varies between US $3,230 and US $11,970, according to income and age. Above this maximum amount, citizens are reimbursed. The second model is the Beveridge model, named after a man named William Beveridge, who designed Britain's National Health Service. In this system, healthcare is provided and financed by the government through tax payments, just like the police force or a public library. Many, but not all, hospitals and clinics are owned by the government. Some doctors are government employees, but there are also private doctors who collect their fees from the government. In Britain, you never get a doctor's bill. These systems tend to have low cost per capita because the government, as the sole payer, controls what doctors can do and what they can charge. Countries that use this model include Spain, Italy, and in the US, the Veterans Administration uses this model. Cuba represents the extreme application of the Beveridge model. It is the purest form of complete government control. This is the model that most Americans probably have in mind when they think of socialized medicine. The next model is the National Health Insurance model. This system has elements of both the Beveridge and the Bismarck model. It uses private sector providers, but payment comes from a government-run insurance program that every citizen pays into. Since there's no need for marketing, no financial motive to deny claims, and no profit, these universal insurance programs tend to be cheaper and much simpler administratively than American-style for-profit insurance. The single payer tends to have considerable market power to negotiate for lower prices. Canada's system, for example, has negotiated such low prices from pharmaceutical companies that some Americans have spurned their own drugstores to buy pills north of the border. National health insurance plans also control costs by limiting the medical services they will pay for or by making patients wait to be treated. However, any emergency service will be treated immediately. It is usually elective surgeries that people have to wait for. The classic national health insurance system is found in Canada, but some newly industrialized countries, such as Taiwan and South Korea, have also adopted this model. One thing I want you to know is that contrary to what many people believe and what many politicians might claim, Canada is actually not socialized medicine. Providers are private and privately owned and operated. The government does not own medical practices and hospitals. In contrast, Britain's National Health Service is actually socialized medicine, because the healthcare system is entirely run by the government. The government is both the provider and the payer. Many people like to lump Britain and Canada into the same healthcare category, but the fact is they are actually different. So next time someone talks about socialized medicine in Canada, you can politely point out that Canada does not, in fact, have socialized medicine. Only the developed industrialized countries, perhaps 40 of the world's 200 countries, have established healthcare systems. Many developing nations are too poor and too disorganized to provide any kind of mass medical care. The basic rule in such countries is that the rich get medical care, the poor stay sick or die. In many developing countries, hundreds of millions of people go their whole lives without ever seeing a physician. They may have access, though, to a village healer, using home-brewed remedies that may or may not be effective against disease. In the developing world, patients can sometimes scratch together enough money to pay a doctor's bill, Otherwise, they might pay in barter form. If they have nothing, they don't get medical care. In some countries, such as Haiti, even if patients are admitted to a hospital, the patient and the patient's families are still responsible for providing the patient's food, clothing, and blankets. The common principles that all models hold is that each one strives for coverage, quality, cost, control, and choice, but these are all followed to varying degrees. The Beveridge, Bismarck, and National Health Insurance models all provide coverage for every resident, no matter how young or old, rich or poor, sick or healthy. This is a basic moral principle of virtually every country with one of these three healthcare models, with the exception of the United States. It is easy to say that other countries ration care, but it is important to remember that care is also rationed in the U.S. Most insurance companies require pre-certification or approval for certain treatments or surgeries, and often they might deny coverage. This itself is actually a form of rationing. As we will see in the next few slides, many other developed nations actually deliver better quality care than the United States. The U.S. is not number one in healthcare outcomes. Far from it, in fact. The U.S. has by far the highest cost for healthcare than any other country in the world. In addition, many other countries offer greater choice in treatments and providers than Americans have. For example, if you think of your own personal insurance plan, most insurance plans tell you where you can and cannot go and which doctors you can and cannot see on the basis of in-network and out-of-network. In contrast to the four models that we just discussed, the United States operates on none of these. It largely operates on a business model. U.S. healthcare is very expensive, it produces mediocre outcomes in many cases, inadequate and inequitable access is permitted, and the overall healthcare industry is one that is mainly profit-seeking. Patients and doctors alike have bottomless expectations. When you consider all of this, it does make you wonder, are we actually getting our money's worth? To give you a basic idea of what healthcare coverage is like in the United States, I will begin by telling you something that you probably already know. The U.S. is the richest country in the world. However, despite this, the U.S. is the only developed country with no universal coverage scheme. In fact, we are ranked last out of 23 nations in providing universal coverage by the Commonwealth Fund, and that is precisely because we have no universal coverage. Our model is extremely fragmented. In fact, in our entire health system, we have elements of all four models. If you are a veteran, your healthcare system is like Britain's or Cuba's. If you are an American over age 65 and on Medicare, your healthcare system is like Canada. If you are a working American who receives insurance through your employer, your healthcare system is like Germany. If you have no health insurance, your healthcare system is like many developing nations. Citizens in the U.S. face the risk of financial ruin due to exorbitant medical bills. The ACA, passed by President Obama, offered coverage to millions of people who previously had no access and did away with the insurance company's refusal to cover pre-existing conditions. However, health insurance still remains unaffordable for many families, and others have seen their premiums significantly increase. We will continue this lecture in part 2.